I think for surgeons, we're going to make care better. We're going to come to the true era of precision medicine and customized medicine.
Hi, I'm Gabriel Jones, the founder and CEO of Proprio. We got a really exciting group we've gotten together today. Dr. Shah, Sabdani, and Mianji have joined us from the HARM study group, which is the most leading preeminent pediatric spine study group globally, numbering about 40 leading surgeons across the world from about 30 of the top hospitals and institutions that work in the area of pediatric spinal deformity and degeneration, conditions like scoliosis. We're all very mission driven and mission aligned to solve these problems for these patients. So I really couldn't pick three better clinicians and leading researchers to talk with today. Primary topic and subject matter is a really exciting partnership between Proprio and the HARM study group, this leading institution. So I want to just kick it off by sharing that excitement. And this is a new kind of partnership between sort of technologists like us at Proprio here, sitting in Seattle in the shadow of Microsoft, Amazon, Google, Apple, all these leading technology companies like NVIDIA, and really for the first time stepping into the healthcare space and getting to work really closely with leading clinicians and researchers like the three we're honored to have today, some time with today. So Dr. Mianji, if you could say a few words about this novel collaboration that we've dreamed up and you and your team have honored us with the opportunity to work with you on. It'd be great if you could say a couple lines about where this idea came from and sort of the power of it and how it's different. I'd appreciate it.
Well, thanks, Gabe. Thanks for inviting us to join. And just as excited as you are, I think from the Harm Study Group, we're very excited about the new collaboration and partnership. I'd say it probably began quite organically. The Harm Study Group, as you know, has been around for 30 years, and kudos to the leadership who really pioneered this concept of data-driven outcomes research. And the Harm Study Group has done really just that. So we have a lot of data where we follow patients longitudinally. I think now in 2025 and the way computations, data acquisition has become much more sophisticated, and we felt it was probably time that we pivot in that direction as well. Beyond looking at your hardware and what it might be able to do intraoperatively, I think, Proprio really let us know about your capabilities of data acquisition. And so that concept of automating data that we are collecting, and we wanted to do it in a more sophisticated manner, we might also gain insight in other areas of what truly is background noise versus not, and the sheer amount of it. We thought that this is probably now the way to go, and just as excited as you are that this occurred organically, and it was really nice to really understand both institutions, Proprio as well as HSG, and like you said, I think our missions are reasonably well aligned, so hopefully we'll get there and improve those outcomes.
Yeah, I like. Thank you for going through that. The why now. When we started Proprio out of the University of Washington's computer science department 10 years ago, the graphics processing units, GPUs, algorithms, and all this excitement globally around AI was frankly not even a twinkle in my eye. Maybe some others could claim that they saw around that corner. We were trying to invent ways to be clinically impactful, so-called earn the right into the operating room, right? And whether that was robots, cameras, sensors, computer vision, et cetera, some way to directly impact the lives of clinicians and their patients has been our North Star all along. And we thought it might be very valuable to go acquire all this information from the operating room and be able to connect it with organizations we didn't even know existed at the time, such as HARM Study Group, who spent 25, 30 years collecting very valuable data on what happens with patients after the surgery occurs, and trying to drive groundbreaking research. So maybe one of you could speak a little bit to what we think the impact is on clinicians, patients, and research of being able to truly connect the dots between preoperative information, intraoperative information, and the very valuable postoperative data collection that Harm Study Group has been working hard on for 25 years plus.
Sure. So, Gabe, I can go ahead and kick that off. And firstly, thank you for the invitation here. I can tell you It is truly exciting to see what we hear around us all the time about AI and predictive analytics and everything that we are seeing being implemented across all these different fields, making it into not only healthcare, but also specifically to the patients that we treat. And, just generally, I would say we have made tremendous improvements in the way that we treat these patients. I've been doing this for 20 years, and I can tell you, we have made a lot of advancements over the years, and the harm study group has actually helped us to make those advancements. But it feels that the way that we've been doing things, the advancements have been incremental, and there's been a time lag on how quickly those advancements are actually eventually translated to our patients. Because currently, as much as we try to make the patient's journey across our systems as a continuum, there we really are siloed preoperatively, intraoperatively, and postoperatively. So what I see this technology helping us to do is it's really going to create this continuum, because now we're going to have not only more efficient data acquisition, it's going to be more accurate. We're going to be able to tie not only clinical and radiographic parameters, but there's going to be parameters and data values that we don't even know exist, and we're going to be able to make these new connections, which are going to have a tremendous impact on our patients. So I see this as really tying the entire continuum of patient care, because now we'll take our patient preoperatively. We'll be able to come up with a plan that we want to execute intraoperatively, and then we will execute that plan, which today we really just base it off of two-dimensional X-rays. But now we'll have a much better understanding of alignment, perhaps the 3D correction that we're trying to obtain. We'll be able to understand, where are we perhaps spending more time in a procedure and less time in a procedure? Where are the next generation of advancements going to come? And then subsequently, we'll follow these patients post-operatively and be able to tie in how these patients did with respect to not only paper-based health-related quality of life measures, but real life clinical measures, where we'll be able to understand, are they actually functioning better? How are they doing overall with respect to, a wide variety of health parameters post-operatively, with the ultimate goal that when we see a patient preoperatively, now we're not just going to base what we're going to do on that patient on specific surgeon experience, but now we're going to actually have an algorithm that's not only going to tell us, hey, listen, this patient's going to respond to a particular treatment form, but also give us an assessment of what the risk of that patient may be, perhaps for complications, and what we can do to try to minimize those.
Absolutely. No, you said it perfectly.
Gabe, can I just add to that, if that's okay?
Please do.
I mean, Amr said it so eloquently, but in addition, I mean, historically and even to date, much of what we have been able to do has been very descriptive, right? You see observations, you have data, and we can just describe what we see, and Amr said this so beautifully. We have been able to, in some fashion, predict, we have a set of outcomes, we've described it, and then, the next item will be this. Now, with the ability of systems like Proprio and just the sheer volume of the amount of data and how it can be computed, hopefully we can prescribe. We don't just give somebody a risk of what a complication might be or what an unplanned return to the OR at a certain period of time might be. We may be able to tell surgeons and healthcare systems that this is what you need to do to eliminate that risk of a 30-day reoperation or readmission. So Amr said it just so beautifully. It's that surgical journey that I think will be impacted completely, like all along that continuum that he said.
Even better. I can't do nearly as well good of a job as the two of you did, but maybe one of you could speak a little bit to coming into surgery now. You've all had multiple years, decades of experience to perfect your craft. And new technologies have been introduced, such as navigation, robotics, image-guided surgery, and now AI is starting to impact all of these areas, right? Hopefully, obviously, and measurably for the better. Could you speak a little bit to the collaboration, research that we plan to do together, and how that impacts the next generation of surgeons that you'll be training to use these techniques and be the surgeons that lead the way going forward? This is an area, I think, of passion for all of us, and you as clinicians teaching that next generation. Any of you that would like to speak to that topic, I'd love to hear your insights.
Yeah, sure, Gabe. I'll take that one. I think right now the the best teachers are ones that are inspirational to their trainees, and maybe they gravitate towards a field like ours because they like what they see. They like the teaching environment. They're excited to come in every day and participate as part of the team. And the teaching part is iterative, just like Amr was saying about our progress and innovation. You have a set of skills, but you can get better at those skills through repetition and deliberate practice and getting feedback. I think this tool is going to really leverage the feedback part. We will be able to see shortly after the case, or perhaps someday in real time, where we can improve in efficiency, ergonomics, ethnography, and just execution procedure from skin to skin. And then in the next case, get better, the next case, get better. It also prepares you for curveballs and unexpected events. When you're very comfortable with the routine environment, then we can perhaps simulate changes in the operating room that occur in real life, but this would be in a simulated controlled environment where we could use that also for teaching. Loss of signals, hypotensive crisis, self-extubation of the patient, all kinds of disasters that we've seen in the operating room. But when we've seen them before, you can respond to them in a much better, safer way that's going to provide a better outcome for the patient. I'm really excited about the teaching part. And I think that it can be also customized. We've been talking about customized medicine for a patient, but the teaching and the learning journey can be customized as well. They need more of this. Oh, they can skip that module because they've already mastered that, and so forth.
No, I completely agree. And candidly, we hope that taking this very data-driven approach to training the next generation of surgeons will not only accelerate their training and improvement across the board, but give them the ability to come back and ask better questions.
Yeah.
Hey, here's what we saw in the case yesterday. That's a little different than what we saw in this kind of similar case 6 months ago in my fellowship. Can you tell me the nuances of what you see here? And let's measure those and replay and relive and then simulate the very next one when that sort of a case or that situation comes up again.
Yeah.
I get very excited when we here in Proprio's headquarters can run 8 to 10,000 simulations for an upcoming cadaver lab or a live case to see what specifically on a pixel by pixel basis on a display for a surgeon, how much more bone should be exposed to place the implant in the very optimal position. Yes, to have the perfect osteotomy, no more, no less. Right? These are things that have just been dreams, right? And industry brethren have been trying to build robots to do these kind of things for some time. I would like to think that the data set we're collecting with Proprio and these kind of collaborations would set up the very next generation of not only robots, but implants and every product that you use, and really being able to simulate what is the optimal thing for this patient that's coming up for us tomorrow and next week. Those capabilities, I don't think, are very far off. We're using something similar today and every day here, and we want to make that available very broadly to see the entire industry adopt those kind of approaches.
Yeah, absolutely.
We would
And
call that a step change or a paradigm shift.
as teachers, I think we're going to see things we hadn't seen before either. So
That's a good
that's
point.
the really exciting part.
Yep. I think that goes very naturally into impact and the bigger picture. I'd love to hear from certainly you, Dr. Shah, but anyone who'd like to chime in on what does 5+ years from now look like in the world of spine surgery and in pediatric care in particular?
Well, I think for researchers, this is going to spawn more questions because we are going to be able to analyze complex data sets, separate the signal from the noise, and be much more focused in which research questions are answerable, what's feasible, and what can actually make some progress. I think for surgeons, we're going to make care better. We're going to come to the true era of precision medicine and customized medicine, and perhaps even creating medicine, giving the patient the best plan for the best outcome. And for patients, that's what they want, right? They want safe care and capable hands, but they also want to be assured that the treatment prescribed was best for them. I think we're going to a point where we understand that, but for a long time, we were doing the same operation for a group of patients that it worked for in the big part of the bell-shaped curve, but we learned more at the tails. Who did well, who didn't do well in the extreme environments, and that's where AI is really going to help us well. I think this is It's the dawn of a new era, developing a better care plan for patients, the best care plan for patients to get the best long-term and durable outcome.
Open to any other perspectives or comments that you, Dr. Miyagi, Dr. Sandani, would want to add to that. What does the future look like from your perspective?
Yeah, so
Eager to
I'll
hear.
just go.
It's very hard to add after Sukin.
The only thing I'll
Yes.
say, just off the cuff, mainly is, we all work at the academic institutions, and clearly we have a tripartite mission of clinical excellence, research excellence, educational excellence, and this is going to have an impact across all three. And just to chime in a little bit more on the clinical side, what I would love to see is I would love to see the learning curve for new surgeons get really shifted over to the left. So then if a patient comes in to see, whether it's a new surgeon that's 3, 4, 5 years out, or they come to see a Dr. Shah or Dr. Mianji, that their experience, the variability in that experience gets decreased. That's where I think this data-driven information is going to take us.
Yeah. You're talking about decreasing variability, improving standardization, but also, that plateau from intermediate to expert. I think this can really shorten that plateau or at least make it a little bit less rocky. People have a hard time going through that plateau in anything they're learning. This is going to be a step up.
Yeah, and I think what will help drive that is, what we all in some aspects worry about automation, but I think in this area it's crucial. If you really look at the way we collect data now, you could argue that it may not be standardized from center to center. You might have intraoperative variables reported on in terms of skin incision to closure, et cetera, by somebody at one center in the operating room and taking notes. Some other center might do that after the fact and looking through the chart. So, we are still at risk of data holes and empty data, whereas this being real time, prevents that. And it gives both accuracy, but it also gives the entirety of all the data fields that we're trying to capture. And I think to Sukin's point, going for intermediate to, expert or super expert, we may not know what we should be looking for. But if we're capturing everything and we're able to then, use sophisticated algorithms, again, for that feedback, then we may know, and maybe that intermediate to experts already there, but they just don't know that either. So I think the opportunity and the ability of Proprio really to provide that real-time data capture is really crucial, especially when you're looking at, just research and the validity of research overall, decreasing variability among sites, standardizing things, capturing everything that we want to capture without any data holes, makes that analysis of all that data a lot more concrete, a lot more valid.
Yeah, and
Hey,
hopefully the
can I
objective data and ground truth helps us to get there. Sorry, Dr. Shah, go ahead.
Yeah, can I ask you a question, Gabe? Because for this comment just stimulated a question in my own mind about human performance or surgical performance. So just as we can analyze the best hitters in baseball, the best golfers in their swing, the best tennis players, um, musical performers, they have they have certain characteristics that can be analyzed and then propagated in their trainees or whatever. Do you see this technology being able to do that for surgeons by saying, "Hey, Doctor So and So misses less pedicles, and that's what makes him efficient," or the way that Doctor So and So exposes makes him efficient. The way that um, Dr. So and so contours her rods provides for better alignment parameters. What can you do for surgeon performance that might be very helpful?
You absolutely hit the nail on the head, Dr. Shah. I mean, that's what we're here to do, is provide that objective measurability and the comparison that can be done.
Okay.
And the partnership with the Harm Study Group on a global basis is really all about creating this community of data sharing so those kind of comparisons can be made. So the first step is earn the right to be in the operating room. That's about impacting in a positive way the outcomes for the patients. If that wasn't the case, then we wouldn't even be sitting here talking. So we must earn our right in there and be a good partner for surgeons like yourselves. In so doing, we have the opportunity to collect an objective data set that's longitudinal and allows us to create moments like you just said, where the LeBron James, the Steph Curry jump shot release. Oh, but where was his footwork relative to the defender, the screen setter, and the 3-point line all on a synchronized time series in 3-dimensional space? It's a fascinating concept, but we've now executed on that, right? We went from video game fiction to reality. And there's more work to be done there to instrument the athlete and the astronaut. Why not the surgeon, who's responsible for so much of our truly sacred care, right? Whether it's in pediatrics with children or my mother or one of our grandparents or something. This is a truly sacred space. So we have to be really thoughtful about how we go into that space and instrument the athlete who's standing over the patient for 6, 8, 10 hours. I mean, you guys, it's really physically and mentally taxing. So I think it's really important how we do it. We start with being clinically relevant and impactful and measuring that, and then expand to teaching moments. I've actually been honored to go with Dr. Mianji and see him teach in particular. And Dr. Rick Brantford up here at University of Washington is a preeminent teacher globally of spine surgery through AO Spine and other groups. And so we've watched, learned, and listened the nuances of showing a fellow not here, over here on a trajectory or an approach or an exposure. And I've seen the side-by-side comparison. It's today almost impossible for surgeons to be able to pull up those side-by-side views, show 10 seconds of you doing it this way, and here's the perfect or near perfect approach to this technique. And to be able to compare with Dr. Shah or Dr. Lanky or Dr. Mianji just across the entire globe and across time, that's what we're solving for. And I've seen a few of those moments start to materialize with some of these collaborations, but we want to see that happen tens of thousands of times per year across the whole globe. And that's really the crux of this partnership, in my view.
Yeah, I mean, your comments and Sukin and Feroz's comments just triggered another thought in my head. Number one, there's several studies that we've done which where we just can't pick up a objective reason why outcomes are different. It just comes down to an intangible factor that's surgeon related, and hopefully we'll be able to dissect some of that. And then secondly, it'd also be really interesting to see how these new technologies impact surgeon physical and cognitive load,
Yes.
because that's going to play a big role for longevity and obviously better outcomes as well. So just something to keep in mind is being able to show that as these technologies are rolling out, what is the impact on physical and cognitive load of the surgeon?
I totally agree. Dr. Mianji, did you have a comment?
No, I mean, these two eloquent souls have really nailed it. So yeah, nothing more, Gabe.
You said something earlier, and I wanted to just put a fine point on. The goal here is not to replace the surgeon or automate away the art of the surgery. It's first, let's go measure everything as it contributes objectively and in terms of ground truth, if we could get it. We're going to learn a ton just being able to do that first and foremost. And then to each of your points, let's automate the things that make sense to automate to free up the physical and cognitive load so the surgeon can do the things that make great surgeons, experienced surgeons like yourselves, so effective. And if we can free up much of that cognitive load, the automation isn't about, in my opinion, the magic of a great surgeon and a great outcome for that patient, which is really you guys mastering 1,000 different things or more to deliver that result. It's about taking away the things that get in your way to accomplish those goals. And that's what we're very focused on automating away is it not so much what sometimes shows up in the news of an automated suture or something like that. I don't know if that is the thing that should be automated so much as you guys have better tools to make your jobs less difficult. And thus you can focus on the right things more and have more energy and attention to do so. I think that would be a fantastic outcome for 5 years from now. And that's really a North Star for us.
Agreed. And I think automation, it has buckets, right? It has things that you're trying to automate. Like automating data collection and entry is a super positive thing. Nothing's being replaced. You're trying to improve and enhance that process. So I do agree that I think the word automation sometimes has a bad connotation, but in this aspect of research and really understanding and improving patient outcomes, I actually would say it is the way to go.
Completely agree. Well, gentlemen, I could go on for a while, and I feel like if it was happy hour, I'd say 5:30 somewhere. But I really have appreciated this time. Thank you so much. It just again says to me how much we are kindred spirits in this data journey. AI is a set of tools that I hope we can bring to bear on your behalf, on behalf of the patient. And that's what we're here to do at Proprio. So I'm very excited about the partnership. We're just at the beginning, but we're ready to go. And I really appreciate you spending some time together today.
Of course.
Thanks,
No
Gabe.
problem,
Always a
Gabe. Thank
pleasure.
Guys,
Have a good